warm welcome to the last in this series of seminars by the Centre for Public Health and Zoonoses on One Health issues. This afternoon's speaker is Scott Weese. To give you a bit of background about Scott, Scott did his DVM and actually a DVSC in large animal internal medicine here at OBC. He then went on and got board certified in internal medicine by the American College of Veterinary Internal Medicine. Scott's busy. Like I thought I was busy, and then I read Scott's CV. He acts as the Chief of Infectious Control in our teaching hospital here at OBC, but he also holds a Canada Research Chair in zoonotic diseases. For the past year, he's acted as the Interim Director for the Centre for Public Health and Zoonoses whilst Jan was taking a sabbatical. His research is a lot, but it includes many different areas, including work on Clostridium difficile, microbiome assessment, surgical site infections, antimicrobial resistance, methicillin resistant staph, infection control, emerging diseases, and zoonoses. He's authored and co-authored at least 200 papers in peer-reviewed publications, a number of books, and he speaks extensively. Scott, thanks for taking time out of your schedule to come and speak to us. I know about a topic that's particularly, you're particularly passionate about.
Great, thank you, Andrew. Thanks for coming out. So what to talk about here was a bit of a challenge. Obviously, different audience, different backgrounds, different interests. When I talk about companion animal zoonoses, often the big thing I have to emphasize is the why. Why do we care? Why do we need to pay attention to it? And it's sad that we have to do this, but we really do. I think people inherently get foodborne disease and waterborne disease, and they understand wildlife-associated disease, and often overlook the animal aspect, the pet aspect. And there's reasons that's a problem here. Is, okay, not my kid, not my kid, not my kid. That's tongue to tongue right there, that is. But these things happen. We have very close interactions with animals. These are a bit extreme, but anyone who's got kids, you've probably seen fairly similar actions going on in your house. So this is the normal type of activity, maybe on the extreme side. Then we have the stupid type of activity. This is a veterinarian who assured me there was enough alcohol in the system to kill the salmonella from the snake in his mouth. But we have close contact with a wide variety of different species. Some of these species we know a lot about, some we know very, very little about, which means we know very little about their risks. And then one of the concerns I have, whenever I talk about zoonotic diseases, you worry about freaking people out so much, they want to run screaming from any dog and cat that they see. And we have to remember there's a balance. And those are my kids, these are older pictures, but the common theme is they're smiling. There's a positive aspect. We know there are positive health, emotional, social aspects of animal contact in various situations. It's not for everyone. But there are studies showing in healthcare facilities in the community, there are definite positive aspects of animal contact. So we need to balance off, there's a risk, there's a benefit. How do we minimize the risk, maximize the benefit, and how do we actually figure out what those risks and benefits are? Because every animal is biohazard. This is Meg. Meg's not with us anymore. It took a few cookies to get this shot, but Meg's biohazard is like every one of us, right? Every one of you has something in you or on you that could kill me, given the right circumstances. I know it's not a pleasant thought. Mo's trying to figure out how to do it. But it's a fact of life. We are fermentation vats full of opportunistic pathogens that we have immune systems and other barriers to fight off, but every type of exposure to an animal, to a person, to the environment poses some degree of risk. So we can never have a zero risk situation. Besides a pet rock, there's no zero risk pet out there. So again, it's the positive and the negative, it's the cost benefit, and how do we balance those out? And how do we balance those out when we really don't know much about the costs or the benefits? And I'll come back to this a few times. So what I want to do here is talk about some of the things we do know about animal ownership, which leads into a lot of things that we don't know about. And I'm going to use a few different diseases, not because I'm worried about getting information about those diseases in particular, but because they highlight different aspects or different themes that we need to pay attention to. Now, just to start off, some work Jason Stoll did a few years ago looking at people in primary healthcare clinics, doing some survey-based stuff, just to get a general idea of the types of animals, the frequency of animal contact, and people's perceptions, knowledge, and attitudes regarding animal contact. And basically take home is pets are very common. We know that. Various studies, 50 to 60% of households will have a pet. And so that wasn't really surprising. This second bullet point here is really important because we often forget that. We're really trying to improve the recognition or asking about animal contact by physicians. But do you have a pet isn't necessarily the whole question, because over a third of non-pet owning households, there was frequent contact with animals. Might be grandma's cat, the neighbor's dog, friend's house. But we often forget that if we focus on just the animal owners, we're missing a fairly big subset of the population that might have contact and might therefore be at risk. And maybe even be at higher risk because they don't have that normal type of exposure and don't know as much about interacting with animals. Another thing is the higher risk population. So as we know, with any infectious disease, there are some individuals that are at higher risk for getting disease or getting severe disease. And classically, those are the very young, the very old, pregnant, immunocompromised. And those are very common, right? When you think about various studies, you see 20 to 50% of the population in some groups fits into one of those categories. And this is biased because this is in physicians' offices where you're going to see more old, more young, more pregnant. But 50% of the households in this study had one or more high-risk person in them. And a lot of those had pets, obviously. Now, if we look at the pet distribution, kind of typical for Canada, dogs still rule, cats are sneaking up. But a lot of other species. And like I said at the start, we have a variety of exotic species that we don't necessarily know that much about. You say dog, I can tell you probably my list of top 10 concerns, how to mitigate those risks, whether it's vaccination, deworming, infection control, behavior assessment, all this. I can't tell you as much as we get into these rarer species. And there are a lot of them out there, and they're very, very easy to obtain. Now, we often forget about bites and scratches too. So we think about zoonotic diseases. Well, we don't have a good handle on how often they occur. Bites and scratches, we have a better idea, at least at the severe side. We can get studies looking at ER visits for bites. Overall, getting a handle on the true incidence of these is a bit more challenging. But if we said over the previous year, 36% of pet-owning households had a bite or a scratch incident. And the bottom one, again, that's important, 10% of non-pet-owning households, someone had been bitten or scratched. Just a recognition that there is animal contact outside the household that we need to pay attention to. Overall, a 1.6% attack rate, bite rate, scratch rate. And that's pretty impressive, actually, for a complication. 1.6% of people in that year had been bitten or scratched. Most of them were probably perfectly fine, but every bite and scratch does pose some risk. And then just to finish off with this study, again, those high-risk households. Do those high-risk households do anything different compared to the low-risk households in terms of what animals they have, how they interact with them, what they know about zoonotic diseases? Do they know what a zoonotic disease is? And the answer is it's no different. There are no differences in attitudes, practices, animal ownership, or anything between the high-risk households and the low-risk households, which probably isn't a surprise, but it's disappointing nonetheless. Now, a separate study, again, just set the scene a little bit more in this high-risk population. This is another study of Jason Stoll's where we went into the Children's Hospital of Eastern Ontario, a survey of two populations. One was the hematology-oncology patients. And these are kids predominantly with leukemia undergoing chemotherapy, very high risk, period. And the group, kind of a control group, being kids with diabetes. So very minimally immunocompromised, if immunocompromised at all, more long-term management of this. And just a couple things to highlight here. Pet ownership, again, was very common overall in both populations, not surprising. Acquisition of a pet is an interesting situation. So how often do people in high-risk situations get new animals? Because anytime we have a new encounter, we're creating some new risk. Right? We bring a new individual into the household, whether it's a person, a dog, or a ferret, we're increasing that risk. And how often do we do that in times of elevated risk from the host standpoint? So if we look at acquiring a pet after diagnosis, so the diabetes group, 50%. Now this was higher, but this group's been in the hospital a longer period of time, at least in the hospital system, right? These are chronic cases. They've been monitored in the facility for a long period of time, compared to the cancer kids who've probably been cared for a shorter period of time. But still, 20% of the kids in the hematology-oncology group had acquired a pet since their diagnosis. And you can see why, right? So you've got the kid, they're sick, they're in the hospital, they're depressed, they've always wanted a puppy or kitten, let's get them a puppy or kitten. It makes sense, that one side of your brain, it makes sense. The other side of your brain says, well, that's the individual that's more likely to bite, scratch, bring in an enteropathogen, change something in that household that's already at high risk. And that was reflected by the fact that the majority of these were what we would deem high-risk pets. That would include reptiles, amphibians, but also young dogs, young cats, because they are more likely to shed things, more likely to bite, scratch, poop in the environment, various things that would elevate the risk of exposure. So not really surprising, but we have to get a little bit of information on this to figure out how we can mitigate that. Now I mentioned a couple times, what's the incidence of zoonotic diseases associated with pets? And we have no freaking idea. You can look up foodborne disease. We can get lots of pretty pictures, lots of pretty reports showing incidence of disease, incidence of hospitalization, number of deaths, economic costs, and all this. And we don't have this for companion animal diseases. And there are various reasons why we don't. I won't really get into that, but we just don't have good data. We have maybe bite data as our best thing. We have case reports. We have limited research reports. We have maybe a bit more with salmonella and reptiles. It's something that's been really followed more intensively than anything else, but we don't have good overall information of what's going on in the community with pet-associated disease. Okay, so hopefully I've started by maybe not telling you a lot that you don't know, but raising some of these issues and why we pay attention to it and what some of these gaps are. Now, one of the things is if we talk to physicians, there's very poor interaction between the veterinary and the medical sides, and probably most of you know that. We don't communicate well, we don't ask each other questions, we don't want to tread on each other's turf. And we often assume the other side's doing it, right? The vet doesn't want to play physician, doesn't want to go over and ask those questions that might be relevant, and the physician doesn't want to go play vet or assumes the other one's going to do it. And too often say, okay, well, the vet says, the dog's taking care of that, don't need to worry about it. The physician says, well, it's involved with the dog, so the vet will take care of that, I'm sure. And we've got this big gap in the middle that no one's taking care of. And as we talk to physicians and physician trainees, it's getting the recognition that pets are part of the household. We need to ask that question, just like you would ask any other kind of risky or just general ideas. Like if you own a pet, your physician should know that. If you own a high-risk animal or do different things with animals, they should know that. And so do you have pets or have you had contact with animals recently? Should be a standard question, especially if someone's sick, but it should be a question going into physician. And it's a challenge to get that. It's getting better in some areas, but it's a slow process. And for those of you that go to physicians, think about how often you've been asked that. Now, this question's gonna be even harder to get. How's your dog feeling today? And it may sound like a strange question to ask, but you can think about it, there's probably some relevance, right? So if someone goes into the doctor because they've got diarrhea, okay, do you have a dog? Yes. How's your dog doing? Well, it was puking last week and it's got diarrhea. Well, okay, well maybe these things are linked. What was your dog diagnosed with? Campylobacter. Well, guess what you have, right? There is some relevance of identifying animal health status because it may be a reflection of what the person's been exposed to, animal might have been the source, and it just increases the general awareness. Now this is a case report from a few years ago, and it's a more extreme example of it, but it shows the need for communication. So this is a 46-year-old woman from Mississippi, presented to an emergency room with a kind of a vague history. Fever, headache, nausea, vomiting, decreased appetite, lethargy, pretty non-specific signs, was otherwise unremarkable health status, otherwise healthy. Somehow diagnosed with back spasms and a UTI, don't really know how, conservative therapy and sent home. 3 days later, she was getting worse over that time period. Went into her primary care physician, and at that point had fever, muscle pain, headache, nausea, and a rash. And as most of you know, fever plus rash raises concerns because there's a lot of nasty things that can do that. This is Mississippi. This is an area with a lot of ticks. There was tick-borne exposure, so we run into a lot of questions of what might be occurring there, and was admitted to the hospital and to a tertiary care facility. At that point, this is where the infectious disease docs got involved, and fever plus rash, a lot of areas means tick-borne disease. In Mississippi, absolutely. They described a concrete area on this person's farm where the concrete looked black because there were so many ticks moving around on it. So a pretty massive tick exposure. They reported all of them being exposed to ticks. And she died 2 days after admission of Rocky Mountain spotted fever, a rickettsial disease, a tick-borne disease. And you may wonder why I'm bringing this up, but there's more to this story, obviously. And where the story becomes relevant to us is that person had 2 dogs, well, they had 4 dogs actually. 2 of their dogs had died shortly before her illness. One 2 weeks before, and 2 weeks before, and then one 22 days before. First dog, weakness, petechiation, pale mucous membranes, thrombocytopenia, abundant tick exposure, kind of screaming tick-borne disease. And the veterinarians at that point were suspecting tick-borne disease, but the dog died the day of presentation, so the samples weren't submitted. The second dog died 8 days later, wasn't examined by a vet. The owner said it died because it was lonely, because it missed the other dog, because they'd never been separated. There were 2 other dogs. They both had been sick around that time. One of those dogs was retrospectively tested for rickettsia and had a massive titer, so presumably had Rocky Mountain spotted fever. So you can see how these go together, right? We've got this person who had a diagnosis that was fairly late in the process and a disease that's fairly nasty if it's not treated early. but treatment can be very successful, especially early in disease. And we've got the parallel situation with the dogs with a likely tick-borne disease and no communication in there. So it raises a lot of questions. Would knowing that those dogs had died changed it? Would the question, do you have any pets? And if the answer is, well, 2 of my dogs died a couple weeks ago, any physician, hopefully who's worth their salt, is going to say, what did they die of? Investigate that a little more. Suspected tick-borne disease, okay, well, you got 2 animals with a tick-borne disease, you've got lots of tick-borne exposure, you've got fever that might be a tick-borne disease, let's start some doxycycline. So you can see how that would happen. So would knowing that have changed things, with that simple question, do you have any pets, maybe have saved the person's life? Who knows, but I think this is a good example of why we need to think about diagnostic testing for animals, right? Having that diagnosis might have helped a lot too. If they'd had a confirmation of rickettsial infection, maybe that would have been conveyed quicker, maybe that would have triggered something. But the communication and the asking that question aspect is something that we still do a very good job of, more broadly. Yeah, I won't really comment on that. Snake soup, I'm not sure who's the soup and who's the... Okay, another case. This is actually a fairly common scenario. I get calls about these probably every couple months or so. 10-year-old boy, otherwise healthy, presented with a fever, rash, arthritis, resolved and then relapsed a week later. Again, we've got that fever plus rash, indicates usually something different going on, referred to an infectious disease physician. Again, this is where things start to get good because they start asking the questions we want everyone to ask. And at that point, we found out the family had acquired a pet rat a few weeks earlier. And the kid had received a very minor bite, and these typically very minor bites get dismissed as it was a little nip, your arm's not falling off, off you go. And it had also been licked by the rat. So we've got a kid that's got a fever and a rash, and it's had a rat exposure. Anyone want to guess what he's got? Rat bite fever. Yeah, some audiences say it's got a rat bite and he's got a fever. What did he get? And it's just over the top. Which again shows that on the veterinary side, we don't learn about these things. I'll talk to veterinary audiences and I'll say that. We've got a kid who's had a rat bite. Now he's got a fever and a rash. What do you think he has? And it just hasn't clued in because no one has talked about rat bite fever or rat zoonoses, even though rats are fairly common pets, and this is not exactly a rare disorder. Okay, so there are a couple reasons why I get involved in these. One is the question of what do we do with this household? So we've got a kid that's been sick, they've been treated, they're better. We still got the rat in the household, and we've got the family that, well, don't want that kid to be in hospital again. What do we do? Do we test and treat the rat? Do we just empirically treat it with antibiotics to get rid of the bug? Do we euthanize it? Do we rehome it, or we say, well, you know, that's just the, you know, the shit happens component of animal ownership. There's always some degree of risk. And we need to think about the biology of the bug, the nature of the household, and a variety of things. So it really comes down to the question, is the problem this rat, is this a biohazardous rat more than any other rat? Is it a management issue? Is it a high-risk household so that exposure is more likely to cause disease? Or is it one of these unavoidable consequences, or at least difficult to avoid? So we need to know something about the bug. So this disease is caused by bacterium Streptobacillus maniliformis. It's a commensal. It's evolved with the rat. It's basically found in every pet rat in their mouth. So there's no use testing a rat for it, because if I got a negative test back for the rat, I'd say, well, it was a false negative. The rat's a carrier. Do we treat it? Well, it's really difficult to treat things that are living where they want to live and where they've evolved to live. It's very difficult to decolonize individuals from a normal commensal. So we could throw a lot of antibiotics at this rat, but it's probably not going to at least be confident to eliminate Streptobacillus. So as a management issue, this is where it comes in, okay, why did the bites happen? Is the rat nasty? Well, maybe it is the rat's fault. Maybe there is an issue with the rat. This is just a behavioral nightmare. Maybe it's the kid was poking at the rat for a little bit and the rat got fed up and bit him. Maybe it's just this new rat in the household and the kid didn't know how to handle it. So are there ways we can reduce that risk of exposure? Is it a high-risk household in that the child was more likely to get disease? No, was otherwise healthy. So you can think about various ways to mitigate this, but euthanasia of the rat doesn't make a lot of sense. Testing and treating the rat doesn't make a lot of sense. It's how do we reduce the risk, or do we deem this risk just unacceptable and the rat should be rehomed? So for me, I guess in a case like this, and this would apply to a couple other diseases we deal with, Capnocytophagocannomorsis, the commensal in dogs, kind of a similar scenario here. So we assume they're all carriers. Don't bother testing them because we know they're probably going to be positive. No evidence that treatment's going to work. Cost benefit, so keep them or rehome, but if we're going to keep them, focus on management, decreasing bites, bite first aid, personal hygiene, and a variety of other kind of just similar, easy, cheap things that often get overlooked because they're easy and cheap and there's nothing sexy about washing your hands. So inherent risk of pet ownership to a degree. Owners need to know specific risks though. and they need to know the practices to reduce that. And one of the reasons so that's one of the reasons I brought this up, just thinking about the commensals and kind of the no zero risk pet. But whose responsibility is it for people to understand this is a really big question. And it's one that's going to be tested in courts a lot more. And here's one that is being tested in the courts, and I can't talk a lot about it. But this is a 10-year-old boy who died of rat bite fever. He had a pet rat, and his grandmother bought a new one from Petco. And he ended up with a fulminant case of rat bite fever where he died very quickly, basically upon admission to hospital. And Petco is being sued for selling basically a biohazardous rat, which raises the question, okay, whose responsibility is it? And we said we can't have a non-biohazardous animal, but what's the responsibility of someone selling an animal to reduce the risk as much as possible? Now, with rat bite fever, we can't really do that. But what's the responsibility of the pet store to say, this is what rat bite fever is, or here are the diseases you can get from a rat, and here are the things you have to pay attention to? And it washes into our end too, and then the veterinary side. What's the responsibility of a veterinarian to talk to their clients about zoonotic diseases? Especially, let's say, a scenario where someone's coming in with a puppy. It's the first puppy they've ever owned, so their baseline knowledge is zero. How far does a veterinarian have to go saying, okay, here are the risks, here are the things you have to do? It doesn't mean an hour conversation, but who has to broach that subject? How much do we have to give them? And if we don't, what's the liability there? And ultimately, liability is going to drive this. And we don't know at what level the expectations are, but something people need to think about proactively. And just another rat bite fever scenario, which kind of shows a whole range of bad issues. This is a 6-month-old baby that died of rat bite fever. Basically, the child was taken into an emergency room with a fever and a rash. Again, the fever-rash combination. Was released being given medication. Probably got Advil for the fever. It said, go home, it's got a baby fever. 2 days later, it had a high fever and lethargic, was brought back to the hospital, died in the emergency room that day, and it had rat bite fever. And what does it say on there? It doesn't say on there. The rat was a rat that they owned to be fed to their pet snakes. So this is where the whole many levels of badness. We got a rat that's not a pet. It's in contact with a 6-month-old, and we got snakes in the household. So, but you've got to think, this information could not have been conveyed to any physician with half a brain, right? You've got a 6-month-old baby, and you've got rats in the household, and you've got snakes in the household, and it's got a fever. That kid absolutely needs to be thought about as a salmonella or rat bite fever suspect. So again, nothing's really said here about that, but you've got to think the question, was there any animal contact, wasn't asked here. Or someone was completely negligent if they dropped the ball and got an answer on that. Okay, another example. We'll make Andrew happy here by getting into parasites. So again, a very common question. Andrew probably gets these many times too. The patient's a 5-year-old child that's undergoing chemotherapy for leukemia. Family is 4 cats. 2 are indoor cats, 2 are indoor-outdoor cats, and they're worried about Toxoplasma. Should the cats be rehomed? This is the question we got all the time in the context of pregnancy maybe 10, 15 years ago when everyone was paranoid about that. And we've kind of toned the you must kill your cat if you're pregnant thing. That it still happens occasionally, not as much as it used to. But as people are getting awareness of immunocompromised, we've got a high-risk individual here. We've got a disease that can be pretty nasty, can be very nasty, and there's obviously concern. You've got sick kids, the degree of scrutiny is going to be very, very high. So when you consider what's the incidence of toxo disease in immunocompromised individuals, well, it's pretty low, but it's pretty bad. So things that aren't that common but are very, very severe, we're still going to pay attention to. What are the sources? Now that's the big thing. Are these cats a likely source? And this is where we have to have a lot of communication with people. What are the odds any given adult cat is shedding toxo? Very low. Indoor cats, exceptionally low. They shed for a short period of time, typically early in life. That's it. Maybe some recurrent shedding as they get old. That's a bit less clear. But exposure to toxo by people is usually not exposure to cats. It's exposure to soil and food and various things. It's cats as a definitive host, so we can blame cats ultimately, but it's not that pet-cat exposure. So bad disease, but the pets in the household probably are fairly low risk, especially those indoor cats that aren't hunting, presumably, in the household. What can we do to reduce the risk of exposure if the cat's shedding? Well, this is a don't eat poop disease, right? And this is beyond a don't eat poop disease. This is a don't eat old poop disease because fresh feces are not infective. It takes time for those oocysts to sporulate. So if the child doesn't have exposure to feces that's had time in the environment to become infectious, the risk, well, there's no risk, right? So we've got low risk of exposure. We've got ways that we can mitigate that risk of exposure. Anything we can do to reduce toxic shedding? Probably not. Is testing indicated? This question comes up all the time, and again, probably not. And does the risk of the disease outweigh the benefits? Again, we're back to what is the usefulness of the cats in the household? If the kids like the cats, getting rid of the cat, someone's making cat comments, right? So if the cats have a beneficial role in the household, then we have to think about the risk of getting rid of them. If, everyone hates the cat, and you get some scenarios like this, where you got grandma died and they inherited the cat because no one else would take it, and now there's an increased disease risk. Well, maybe that's the excuse to rehome. Like, rehome is not euthanized, be clear about that. But if there's a positive aspect to having the cats, we really want to try to maintain them there, especially when you've got a kid that's sick. You don't want to add on one more layer of complication to this. So this is an education talking about things, don't eating poop, which is the big thing. But basics of, your outdoor cat's now an indoor cat. Kid's not going near the litter box. Here's how you change the litter box. Here's how you wash your hands. And we'll talk about, sandbox exposure and soil exposure and food and all the other things that are probably a lot more relevant to Toxo. Okay. Now, again, lower risk populations, these are kind of pets, but these are visitation programs or programs where, schools or whatever will bring in animals for interactions. These are really popular. If you Google them online, you can find lots of companies that'll show up at your house with a whole array of critters and pass them around to what are usually high-risk kids. So they're often marketed for birthday parties. And there's a difference between a birthday party for a 10-year-old and a birthday party for a 4-year-old. In terms of the risk of disease, how well they can handle them, the hygiene practices, and everything else, because we're worried about reptile contact with kids under 5 because of the, the very high rate of salmonella in them from reptiles compared to older populations. But some of these market specifically for those low age group populations. So this is the Child Care Center page for one of the companies that you can find online, talking about bringing these snakes have ears things. So they're bringing an educational aspect, but they're also bringing a high-risk individual into the household. And do people understand that? Again, when they're going into your house with these reptiles, do you understand that there's a salmonella risk and what that risk is and how do you mitigate that? Have you been able to make an informed decision? Whose responsibility is it for that? And a lot of things with the exotic animals is what's the benefit? I'm not going to talk much at all about therapy animals, but you see therapy animal programs in hospitals that are well run with dogs. And you'll see some that'll bring in strange critters. And yeah, it's kind of novel to see a, insert weird species here in the hospital and people will enjoy it. But what's the real benefit of that over interaction with a nice, 3-year-old Labrador Retriever that's, for me, the prototypic therapy dog? We know a lot about it, great behavior, we can assess it. There's still a positive interaction there that may be better than the novelty effect. And that's what these are going for, the novelty effect. And you can see this, if you go on the internet, you can find lots of scary stuff. So we've got snake, the snake being kissed, being wrapped around the neck, a couple issues there. Don't imagine this little turtle's house trained. And odds are these kids are eating right there, right? That's probably where they sit around and have their snacks and their lunch. And then it's spring, so it's hatching chick season, so it's salmonella outbreak season. Because hatching chicks are very common in certain areas. You can go to the feed store. The feed store I get feed from, you can put in your order for chicks right now, or you can put an order for eggs to hatch your own chicks. Schools very often do this with their kindergartens or their grade 1s. And again, they're educational opportunities, but is a kindergarten class the one to do it versus an older class? And do the teachers actually understand infection control, and do they understand the risks, right? Does every teacher know the health status of all their students? Probably not, right? If the kid's been away a lot because they're undergoing chemo, yeah, you're going to know that. If they've got some underlying immune disorder, if they're on immunosuppressive therapy, may or may not know it. If they're outwardly healthy, they're not missing a lot of school, teachers may not understand that they've got a high-risk child in the household. And you see some of, again, pictures from these. There's, the bird on the head, there's kissing the bird. There's the look, mom, what I brought home, bird pooped on me picture. These are all pictures by people that put up thinking this is a great program. And like I said, there are some good aspects. They're all having fun. But that's not really a contained salmonella environment, Campylobacter environment. And the reason we can bring this up is we know this can be associated with disease. There are outbreaks associated with hatching chicks every year. And these are often from large kind of warehouses that send out eggs or chicks. And if you've got a large group sending out something, they can send things a lot of ways. So the same thing with the rodents being fed to snakes and reptiles. If you get a really contaminated facility, instead of just infecting one farm to one house, you're going one facility all the way across the country or even international, where some of these outbreaks can be. So I've talked to these types of talks to long-term care facility groups and child care groups because we get a lot of questions from them because, again, there are definitely positive aspects of animal encounters in those groups, and we need to figure out how to balance them out. And at-home daycare is an interesting situation because you've got the personal pets and you've got the daycare side, and how those interact is always a bit of a question. So I was doing a talk in Waterloo to some at-home childcare group, and basically did the reptile spiel. They shouldn't be in the house when they're under 5 kids and everything else. And at the end, someone comes up and says, I know you just said reptiles shouldn't be in the house with kids under 5, but we have a lizard in our daycare and it stays in the cage. That's okay, right? That's right, I started doing that for a little while. But this is a perception. It's an important perception thing. Okay, I've got a snake, but it stays upstairs, or it stays in the cage, so it's not a problem, right? I'm not letting my 2-month-old baby hang out with my snake for lots of different reasons, so there's no risk. And there is a risk, right? The snake or the turtle may not leave the enclosure and the kid may not go in, although sometimes they do, but the salmonella can get out. So this is just one of many examples. This is a turtle-associated salmonella, septicemia, and meningitis in a 2-month-old baby. The baby wasn't handling the turtle. The salmonella got out, whether it's from changing water, dumping food, whatever, indirect contamination. I used to have turtles when I was in university and a cat, and he used to love coming up there, and I didn't have a top in the enclosure, and try to bat the turtles off when they're sitting on the rock. And if there's salmonella, he's probably tracking it all over the place. So these bugs get out. We certainly know that happens. And this is an interesting one too, just showing where we might be missing out again on some pet-associated data. So this is a foodborne outbreak associated with gravy, and associated with bearded dragons, like not bearded dragon gravy, but gravy contaminated with bearded dragon salmonella. Yeah, it's a weird one. Basically, there was I think it was a church potluck, and it was a foodborne outbreak, a salmonella outbreak associated with that. So because it's salmonella, there was contact tracing. They found the food source, and it was gravy. Right? But they tracked it further. They went into the household, and it was contaminated with a salmonella that they found in this bearded dragon, these little reptiles in there. And the bearded dragon wasn't roaming around the kitchen or anything, and it was owned by the kid. But again, salmonella somehow got out of that bearded dragon's enclosure, got into the gravy, which was improperly handled, which made it to the potluck, which made a lot of people sick. So how often we actually trace some of these even foodborne outbreaks back to pets might be interesting to see. So general concept is high-risk individuals should avoid high-risk animals, but that doesn't always happen if you've got things sneaking out of the household. I'd say little attention is paid to zoonotic diseases in child cares and schools in particular. Schools actually don't want to know. We've tried to get into schools before for various things, and I know other groups that have, and they really don't want to go there. And the bottom one, we often say, well, it makes sense, right? It's common sense, but as you know, common sense isn't necessarily all that common. Okay, I'm going to change tack a little bit here. It's getting into some of the issues we deal with in the hospital, but something that's a broader community issue as well. So bacterial infections and multi-drug resistant bugs. Could spend a couple hours on this. This is a TPLO, tibial plateau leveling osteotomy. Big cut through the bone. We got a plate in there. Very, very common surgery in dogs for cruciate injuries. And it's also one of our higher risk surgeries for infections. And what we find most often in these cases now is this type of profile from staph pseudodermatitis. This is the dog equivalent of MRSA, a pretty high profile human bug. And commonly we see we've got R's down the board. We've got very little that we can treat this with. So from the clinical standpoint, that's kind of our oh crap moment is, okay, I've got this infection that's caused by a bug that's not susceptible to much or anything of what I have. What do we do with it? And then we take that a step further is, who's been exposed? What's the risk? Some of these have minimal human health risk. Some of them have probably fairly significant human health risk. And it's not just staph. This is an Enterococcus from a total hip replacement. You see we've got R's everywhere. Enterococci aren't that virulent, so it may or may not be relevant, but if we have to treat this one, where do we go? And the thing that we often don't think about, we talk about antibiotics in animals, we pay a lot of attention to food animals, which we should, but we forget about some of the drug classes that we use in companion animals are the same that we're going to be using in people that are seriously ill. And it's one thing becoming resistant to tetracycline, it's another becoming resistant to meropenem, or third-gen cephalosporin, or fluoroquinolone that you might be on when you are seriously ill or septic in ICU. And then something that's becoming a big problem now is these multi-drug resistant gram-negative bacteria, these ESBLs, extended spectrum beta-lactamase producing gram-negatives, where we see them susceptible basically to amikacin and imipenem. Neither drug that we want to use. Neither drug is easy to use. There are issues with them all. And something that we're seeing for a couple reasons. Now, what we kind of get into these days is this kind of alphabet soup of badness, what I call it. We've got multi-drug resistant, we've got Staph aureus, Staph pseudomonas, we have carbapenemase producing Enterobacteriaceae, the next level of those resistant gram-negatives. Enterococci, we've got NDM1, we've got MCR1, this more recent high-profile thing that's been found in food animals and food. And the dynamics of these are very interesting because some of these are bugs that we're brewing in the veterinary side. We use antibiotics in animals, they get resistant, they go into the animals, and maybe they spill into people. A lot of these are actually coming from people. If we look at MRSA, if we exclude the livestock MRSA, which is more of a European issue, MRSA, dog, cat, horse, rabbit, this is usually human origin. The ESBLs, these gram-negatives, most of these, or very many of these, are very similar to human strains. Probably what happens with a lot of these things is they build up in the human hospital, they come into the community, and then just like at the start, who do you have contact with in the community? Well, your pet. So we see these things spill over. So what's building up in the human hospital is washing over into animals in the community, in animals in hospitals. So there's this very complex dynamic that we often, I think, forget about. And sometimes I say this, so think about the interaction you have with different individuals. So many of you have pets, most of you have pets. So if you have a pet, think about the individuals, animal and human, that you spend the most time with, have the most close contact with, in its intimacy, duration, however you want to describe it. So most people, that's going to be like their spouse, and then their small kids, and then their pet. And some people like their pets more than their kids or their spouse. But think about how you interact with okay, so I've got a dog, I might rub his bare belly, he might lick me in the face, even though I don't particularly like that. You might bathe him, you have that close degree of contact. I don't tend to do that with many people. Same with my cat, right? You might sit on the lap, it's going to curl up on the bed, it's doing things that you don't have those types of interactions with a lot of individuals. So we have ample opportunity to move things back and forth. And I think we're realizing that we do that actually much more commonly than we've assumed. If we cultured you and your dog, and we get Staph aureus out of your nose and your dog's nose, but a 50-50 chance it's the same Staph aureus. Probably went from you to your dog. If we find Staph pseudomonas in your nose, almost certainly it came from your dog. It doesn't mean either one of you is going to be sick, but it just means that we can look at it, we're cycling things back and forth with our animals on a daily basis, if not more often than that. And sometimes it is a problem. Most of the time these are just commensals, and it's interesting from a microbiota standpoint, but it isn't going to hurt us. But we have some of these that do, and MRSA has been kind of a poster child for this because it's a high-profile bug, it kills a lot of people every year. Animals are a very small component of that, companion animals at least, but they raise a lot of profile. And just an example of how things can move around. This is one of the first ones we investigated, and I'm just too lazy to make new slides, but it shows things nicely. So this is a clinic in the US, and they had 2 kittens that were identified as having MRSA rhinitis, nasal infection. They probably didn't. They probably had viral rhinitis, and they were MRSA carriers in the nose, but they were diagnosed as that anyway. So we were doing a study at the time looking at people in contact with MRSA positive animals. So we got swabs from people in the clinic, and a technician was positive, same strain. A strain called USA 100, the most common human strain in the US. The technician had worked on these cats, 10, 15 minute appointments, held them, she got sneezed on, probably didn't wash her hands, as Mo can attest to, but just a normal occupational contact. So we took this a little further though. We went into the household, and both owners and the other cat in the household were also positive, same strain. And then if we go even further, these kittens came from a rescue facility. The only contact of anyone or any animal in the rescue facility, in the home or the clinic, was that point of adoption. So the rest of the kittens in that litter died, presumably not of MRSA, they just died of something else. The person who ran that facility was positive with the same strain. Mama cat was negative. So presumably what happened here is this person was positive, infected mom transiently or the kittens or both. One or both those kittens brought it into the household, spread it to everyone else in that normal contact, came into the clinic and spread it to the technician. No one got sick, which is the good thing. But if you're carrying MRSA, you're at increased risk for an MRSA infection. So there is a concern there, even though animals weren't necessarily a source of disease here, but showing that potential for silent interspecies repeated transmission of something like MRSA. And we could probably see this with ESBLs and other things too. Another scenario, this is what we call the ping-ponging infections, where the MRSA infection goes, from mom to dad to kid to mom to dad. It just cycles around the household, and it's a real mess, and this is a great example of that. So, great in a bad way. Household of a mom, dad, toddler, infant, and 2 dogs. The father had an MRSA skin infection, was treated and resolved. The mother then had a C-section incision infection with the birth of the second child, treated and resolved, then got a nasal abscess. And you're reading ahead, right? So you're cheating. But anyway, the toddler had 11 episodes of MRSA infection, skin and soft tissue infection, and the infant, I think was 9 months or so, had already at 6. So this is a mess of a household, right? Recurrent infections, a lot of contact with the healthcare system, a lot of stress. It's a high-profile bug. Yeah, MRSA in an infant is certainly a concern. So what happens often is, okay, I don't care what's going on, I just want to kill it. It's kind of the approach on the medical side. So, you know, I don't care who's carrying it today, we're just going to treat everyone, we're going to eliminate MRSA from the household. And that's what they tried. So nasal mupirocin, nasal antibiotic, doxycycline, trimethoprim sulfa, so different antibiotics, bleach baths, triclosan baths, antibacterial soap baths. So trying to get rid of everyone, MRSA from everyone at once, and it didn't work. And you know where this is going, obviously, right? So their concept of family was mom, dad, 2 kids. I include the fuzzy things, and we did find MRSA, the same strain, a strain called USA 300, in one of the dogs. What does that mean? No idea. Was the dog an important source? Maybe. Dog wasn't the original source, right? This is, again, a human-associated bug. But when you've got someone bringing it in, so dad maybe brought it into the household with that first infection, and they're spreading it around, right? And you think about how a dog interacts with a kid, especially, right? There's a lot of close contact, and there's not a lot of hygiene associated with that type of contact. So you can see how it would go back and forth. So plausibly, it certainly makes sense that it's moving around the household, going to the dog, and maybe they did eliminate it in the people, but the dog, who was probably only short-term colonized, MRSA doesn't live in dogs for a long period of time. It's not their staff, but it can live there long enough probably to feed it back in to the household. So we have had households like this where we get the animal out temporarily, and MRSA will disappear along with treating other humans. So it's very, you know, it's very wishy-washy, but it makes sense. Now, we don't recommend decolonization. We don't recommend getting rid of animals in the households, maybe getting rid of them for short periods of time. But it's part of that dynamic at least need to consider, right? The household is every animal, every individual, including traditional animals and people. And I think it just reinforces, this is the confusogram, as John Prescott calls it. This is the epidemiology of antibiotic resistance. And it's probably even much more confusing than that. You can toss in other things. But we have to remember, we've got companion animals, and there probably should be a lot closer. There's a lot of interaction between different species, between companion animals, between livestock, between wildlife, between humans. And too often we work in our bubbles, right? There's a study on whatever in long-term care, and one in acute care hospital, and one in dogs in this clinic, and one in wildlife, and we don't tend to integrate very well. And that's what we really need to do to figure out some of these situations. Okay, just really quickly, I mentioned service animals before, and the therapy animals before. And these are very, very common programs in Canada. As you know, the majority of hospitals allow animals to come in. Some of these are very well structured, very good programs. Some of these are, oh, there's a dog here today, okay, that's the way it goes. So we're trying to improve the structure, but if you look at it again, the 2 sides of your brain need to come in here. So what's the first thing you see? Anything? Okay, so we got the paranoid people back here. So we've got the immunocompromised aspect. So we have the increased risk here. What's the other side of it? Yeah.
Oh, I was going to say the dogs are touching the face.
Right. All right. So we got more paranoid people. What's the other side of the brain? Happy people. All right. Good. So, and we have to remember both sides of that. Okay. So everyone's happy. Everyone's smiling. Right. So and we definitely know there can be positive health benefits. But yeah, there can be risks, and you've pointed out some of the risks. And the key thing is, how many of these risks can be mitigated without screwing up the programs? And we can. So the top one here, we got the high-risk kid. We've got the dog in the living space, right? If Norley's walking through the hospital, dragging the bed sheets on the ground behind them, would you consider that appropriate? No is the right answer to that. But have we done the same thing by putting the dog that's walking around, laying down right on that living space without a barrier? But we can prevent that. We can keep them on the ground. We can put in a barrier. What's going to happen here? Everyone knows what a golden's going to do next, right? Tongues coming flying, right? And we can reduce that type of oral exposure with still really good contact. Same thing here, big nose, MRSA site, big tongue. And then we've got the little dust mop. We've got an invasive device, an IV catheter in the hand that's in contact with the dog, and it's in his living space. So we can do a lot of things with these programs that are really simple, like wash your hands, use a barrier, don't let them have contact with invasive devices, screen the animals in terms of their behavior and their syndromic status, so they don't have diarrhea on the day they're visiting, things like that. So we can do a lot of really basic infection control practices to mitigate those risks and maximize it. And that's the same thing for households or any type of companion animal contact. And we can avoid higher risk things. And this comes back to the novelty factor I mentioned before, right? So she's happy. It's kind of cool to see a pony when you're in the hospital or a miniature horse. But would she be just as happy playing with a lab? MRSA is endemic in our horse population in Ontario, a couple %. probably not house trained. There are various other things that might pose an increased risk. And then we get into the dumb, right? Okay, we've got, this was Eastern Ontario. There's a llama, I think, a llama and alpaca visitation group. Yeah, and it's interesting, but these things aren't house trained. That's flecks of, hay, manure, whatever. Like, I own llamas and alpacas, and it's just dumb. So, like, I like the critters, but they, they spit, they can bite. Some of them can be very nice, but what's the advantage of bringing a llama in versus the nice dog? And then we get into the really dumb. This is a screenshot from a program in San Diego talking about how good their animal therapy program is. We've got presumably a highly compromised child, and we've got the ultimate salmonella vector, not litter trained, presumably walking in that child's living space. Like, this is abuse in my mind, really. We're taking the ultimate salmonella risk situation and bringing it into a high-risk environment. So we've got dumb things that happen. So if we can tone down the dumb, improve the good, we can maximize the benefits of these programs and animal contact in general. Okay, and just somewhat light on the flip side of this. Okay, so I don't know how many of you know your bunny medicines. We'll have you think about bunny medicine here. So an 8-month-old male rabbit presents with a 2-day history of anorexia, epiphora, bruxism, hypersalivation, and ataxia. Shortly progresses to more neurologic badness is really all you need to know. Negative for encephalitozoan caniculi, potentially zoonotic pathogen, one of our more common causes of neurodisease. And Toxoplasma, owners probably wisely decided not to spend a few $1,000s in MRI on their neurological bunny, and it was euthanized. Anyone want to guess what it might have or why I'm bringing it up? Listeria? Good question. Nope. Comes back to the whole communication, asking questions. I mean, this is one where we're never going to ask the question we need to ask, but this rabbit had herpes virus. So rabbits and chinchillas are very susceptible to human herpes virus. And the owner here reported a severe flare of labial and facial lesions 5 days before the rabbit got sick. So again, how many questions can we ask? You're not going to go into the clinic and say, okay, I've got a neurologic bunny here, like, got herpes. It's not going to be good for your practice. But that's just kind of a fun way to end it off. But I think it shows that we do need to communicate a lot more, even though we're not going to do it in those situations. We need to be thinking about how we can improve our interactions, how we can really do, I hate the term, the one medicine, one health approach, how we can actually do it, as opposed to just say it because people are already saying it. But we've got a long way to go, but we also have a big reason to do that because of the role that companion animals have in our lives. So they don't always do it. We have to remember that. Sometimes they do. We have to remember that too. We have to find the nice middle ground. And with that, I'd be happy to take any questions if there are any.
Scott, thanks very much. Any questions, Scott?
Okay.
Working in veterinary dermatology, I deal with MRSP patients all the time. Some of the dogs we see are they go into hospitals.
Mm-hmm.
How worried should I be about potentially giving MRSP to a bunch of patients in a hospital?
It's kind of multiple facets to that question, so it's great. So MRSP, so methicillin-resistant staph pseudonemedia. So this is our MRSA analog in dogs. So staph pseud, the way I kind of describe it is, think about, okay, methicillin-resistant staph are no more virulent than their susceptible counterparts, right? They're no more likely to cause disease. The problem is when we don't treat them right. So what percentage of dogs carry staph pseudonemedias on them normally? Most of them. Okay. So if we say, what, 43% of households had contact with a dog in that study, we're looking at millions of people in Canada have contact with staph pseud carriers every day. And you will see infections reported in the literature, but these are oddball, N of 1 things. So whenever you see an N of 1 case report in the literature, it's really, really bloody rare. So it's an oddball infection, but it's a pathogen. The methicillin resistance aspect just changes the treatment. Now that being said, I don't want an infection caused by that thing that's up there with ours down the board. So we have to balance, again, a very low risk with some degree of prudence. For me in households, I don't recommend anything special for MRSP, like wash your hands and things like that. In the clinic, we have a higher level because we don't want to transmit it to our high-risk patients. Human hospitals are a different story though, right? The more that risk elevates from the individuals in contact, the more I'm going to be concerned about it. So with international guidelines for therapy animals, visitation animals, and recent antibiotic exposure is going to be an exclusion factor, and active or recent disease would be an exclusion factor. So they would be excluded based on that. Now the question that comes in, well, if the programs follow that, the question that comes in is, okay, after we treat this dog, and let's say it's a month later, is it still an MRSP carrier? Maybe. Right? Is it a greater risk than your average dog being an MRSP carrier? Probably, yeah. Could any random dog off the street also be an MRSP carrier? Yes. So how far do you go? So I think in the acute phase, it's easy to say no, they don't go in because they're sick and they've got antibiotics and for them, they're at risk of getting something too. So you got a dog that's got active pyoderma. Last thing I want is MRSA on top of that because someone deposited it on there. So we can sell it on both sides. It's how far do you go with the knowledge, okay, this dog's more likely to be an MRSP carrier. But the other side, and this is kind of a long rambling answer, is for that dog that's now a month or two post-treatment, if you said to me, list the top 5 zoonotic pathogens this dog probably has, MRSP is probably not going to crack that list. Pasteurella is going to be probably number 1. And MRSP might be up there, but say overall risk, yeah, that dog's more likely to be shedding MRSP than your random dog. But is that dog more likely to cause disease overall than your random dog? Probably not. So I think we have to have some degree of practicality there, is that we can't stop everything. And this is why we do wash your hands before and after contact, and you don't get up on the bed without a barrier, and you stay away from the invasive device, all these other things too. So I don't know if that kind of answered it.
It does, yeah.
Okay. Yep.
Scott, in the food-human health side, the large number of the, say, foodborne outbreaks or cases cannot be actually linked back to an etiological agent. I was just wondering is there anything we can learn on the animal health side? Like is there a lot of cases where you can't really identify the agents that are causing illness, and is there anything we can learn from what's going on in terms of trying to predict the emergence of the next emerging pathogen?
Illnesses in the animals, you mean?
Yeah.
Yeah, well, we certainly have, what we see in animals very much parallels that in humans. And I think companion animals probably even more so because we're in similar environments. We have similar, ecological, outdoor wildlife exposures, and we interchange things. And a lot of this stuff is diagnosis driven. Like, as you know, if we see carbapenemes producing Enterobacteriaceae in a population, you start going there. The problem with companion animals as a sentinel is they would be very good sentinels if we paid attention, but we just don't have it, right? We don't have good surveillance systems. So if 50 dogs in Guelph died tonight of respiratory tract disease, would we know? Well, maybe here, reasonable chance. Like I get a lot of reports of these weird things. We try to act on them, but there's no formal way to do that. It's something we're trying to set up. But if we have, okay, here's what our baseline level of disease is, and all of a sudden we've crossed that threshold, now we need to pay attention to it. Similar to syndromic surveillance in humans, but the problem with companion animals, we just don't have a mechanism for that because no one funds companion animal type surveillance, which is probably the main reason to do it, and there are very few of us that care or pay attention to it. So I think the potential is great for that to be there. It's just a matter of being able to roll it out. And I think in some ways it might be easier than in humans at some degree because people will pay a lot of attention to their pets, and people in some ways might be more likely to report minor health problems with their pets than their own. So I think we could probably say if a person had mild diarrhea or the dog had mild diarrhea, we might get them more willing to report their dog's mild diarrhea in a really, really easy way. We've been talking about app type systems, so click, my dog had diarrhea today, get some really basic incident data. So the potential is there with kind of real-time electronic syndromic things if we ever get the money to do it. So it's a yes and no. Yeah.
Any questions?
Jen?
Scott, just going back to one of your early examples about the person with Rocky Mountains fever as well. Have you yourself, or do you know of anybody who is submitting such things to the human medical journals, either as what your diagnosis of vignettes or case reports or something, as a way of sort of maybe generating some thought and discussion?
Yeah, that's a great. How do we get into the human medical journals is the good question. So often these get written up, which always bugs me, by the physician in the micro lab. So you'll see the staph pseudomedius case and whatever, and you read it and say, they know nothing about the dog side of this, right? Because they didn't bother testing the dog. They said, okay, it came from the dog, but they also have all these other things, and no one bothered to screen the animal or talk about it. Like I've written a few letters to the editor of these just because they've missed the big picture, right? Because they've missed the species that's really the source. So that's the whole One Health thing. If someone's got this weird case, they get the veterinary side involved so we can investigate it or at least give them the right information. There's a little bit getting into the human side. So we've had a couple of commentaries. Jason Stoll was the lead on one with Jason Brophy and myself, a medical infectious disease specialist. There was a fairly high profile thing in the CMAJ. I've co-authored something in the American Family Practitioners Journal. It's targeted towards kind of the therapy animal side, but again, it's trying to drive a little more awareness. So I think some editors are getting more tuned into it. I think the awareness is coming up. Like it's really, really slow, but the awareness is coming up. And I think the acceptance that we're not James Herriot is coming up too, that we actually do research and surveillance and it's not, we don't just spay, neuter, vaccinate. that there's expertise here that we can contribute. So I think it's happening, but it's happening very ad hoc and at a low level. And I think the key is getting footholds, right? For me, one of the big footholds was getting hooked up with Mount Sinai and Don Low, quite honestly, and when MRSA emerged, because that spread into, okay, they realized we've got the C. diff experience, so now we'll do the C. diff human stuff, and then if anything, they get asked about anything weird, so okay, call Weese. Like it's ad hoc, person-driven, as opposed to the medical field recognizing the veterinary fields here, and ultimately that's where I think it needs to go. I don't know how we get there, but that's where we should go.
Scott, I have one question. You continue to say the importance of handling these issues in a balanced manner, and yet you're also saying some of these human cases are going to court. Does that worry you? And where do you see the courts ruling on these issues? Do you think it will be a balanced way or not?
Yeah, it's hard to say where the courts, like it's going to happen in the US, right? Because that's where all these are going. I would say the majority of cases I get consulted on don't go anywhere because they're trying to put too much of a threshold, too much of a blame on, like, these are very complex, right? You could say, okay, let's say I go to a pet store and I buy a dog and then I get Campylobacter from handling the dog's feces and I sue the pet store, right? Yeah, the pet store should have informed me better, maybe they should have had sourced their animals better, but like it takes me 30 seconds to go on the internet and type in new puppy diseases or new puppy management and realize, okay, I can get all these things from it. Because it's such a, both sides have such a big role in here. It's a matter of figuring out, I think, if there's liability. Certainly someone's going to test it really well in a lawsuit and that will drive it. So the first veterinarian that gets sued over not consulting clients properly about a new animal or disease risk or anything else, that's going to raise, I think, the awareness, but it's going to be a slow process because it's like infection control in general. Infection control in veterinary medicine is very reactive. It's hard to be proactive because if we try to implement things, yeah, we can do it, but then people get bored and they don't see the benefit. So we respond. So I think the same thing with the animal side. So a veterinarian, they might say, okay, well, we need to be a little better talking about zoonotic diseases, but you know, if they don't get sued, maybe it's because they were doing a good job, or maybe it's because it's rare, and those things kind of decline over time. The minute someone gets sued, everyone pays attention to it, then it kind of declines a bit. So probably didn't really answer the question.
But do you think in 20 years' time you're going to have certain species banned?
I'm not sure about banned, but I think there's more scrutiny on them. I think, and it's not necessarily, and again, the legislation is all high profile too. It's reactionary things. So you got Darwin, the IKEA monkey, that really prompted a lot of areas looking at their primate restrictions. So and the concern for me on the whole antibiotic side is there are various groups, especially in the US, who are trying to put in fairly restrictive laws on antibiotic use, which are good and bad. But all it takes is one really, really high profile, MRSA infection that kills a kid that gets taken up by someone, and maybe there's an animal link, and maybe they try to bring in an animal link that's not even there, but then all of a sudden there's an excessive response, because it's not hard for someone to put in a really restrictive law and not understand the unintended consequences side to it. So legislation, it's hard to say whether legislation for me is the least effective of any of these approaches, because it's a big hammer that we really don't need. We need improvement in really basic practices. The problem is, how do we improve things? Well, it's teaching people to wash their hands and how to pick up feces properly and how not to get bitten and how to take care of a bite and getting physicians to ask the question and properly manage bite wounds and things like that. Like, this is really, really low gun stuff that no one's going to pass a law for, but that's the stuff that's most effective, so, at least for me.
Any other questions? If not, please thank me.
Thank you. Thank you, Andrew.